Professor of Medicine at George Washington University Medical Center and Director of Infectious Disease Clinic at Veterans Affairs Medical Center in Washington, D.C. She's getting ready to present to you this evening, this afternoon, regarding tuberculosis and HIV infection. So I'd like to present to you now, Dr. Benator.
Good. Okay. I can go that way. So you guys seem you're really far away. So I'm coming out here. One of the things that will help me, because I wasn't able to be here this morning, is to have an idea of who you are. So I guess just raise of hand, first of all, of folks who are in HIV care. Okay, so lots. And in TB care, a smaller number. Those who are in drug dependence, caseworkers, other areas, so lots. Okay. Nurse practitioners, physician's assistants, physicians. Okay, so a small number. Other areas I should know about. So mental health generally. So lots in mental health generally. Okay. All right, I'm not talking about any of those things. No, I'm kidding. These are all relevant for you. One of the things that I'd like to do is ask that you interrupt me with questions, just wave, and I would like for this to be as engaging as possible. It's the afternoon after lunch, so if you need to stand, we can dance, any of those things. So I have the privilege of talking about really a fascinating topic and interchange of topics. And so I'll start through, but please again do interrupt me. I think that, there we go. So it's important always to start with a case. We have a 53-year-old Asian female. She presented in 2006 with cough and fatigue. She's a prior circus worker. Oh, you guys have the pictures. That's not fair, right? Well, so you know that this female who had weight loss of greater than 10% of her body weight is Liz. And this is an elephant. And this is because I want you to be certain that we're not in the veterinary talk. It's that anyone is not mistaking for where they should be. But also just to note that things aren't always as one would expect. And in fact, elephants can transmit TB to humans. So that is not the focus of this talk. This is actually a true story and occurred in Tennessee in an elephant sanctuary. So, there we go. So what we really are here to talk about is HIV, a little bit of an overview, tuberculosis, and a bit of an overview there, but really the intersection of the two illnesses. Why they intersect in such a very complex and difficult way, and why treatment is so complex. So starting out with HIV infection, the number of folks living with HIV infection in the world is estimated to be 34.2 million. So a number that's really hard to comprehend. And this is based on WHO estimates in 2011. In 2010, actually these should be 2011. In 2011, there are 2.5 million new HIV infections, and deaths due to AIDS in 2011 was 1.7 million. So any of you who are in HIV care have seen this curve over many years. And what's shown here is that the CD4 cell count is here in the black circles. With new infection, it declines and then gradually comes down over time. And you can see here that we're out at about 10 years. And it's not until 8 to 10 years that you start to see sufficiently weakened immune system to have illness. The viral load is very high with initial infection, tends to come back down, but increases, again, with increasing time with HIV infection. So the timing of when patients should be treated for HIV infection has gone back and forth from here, or in this period of time where the CD4 is in the 350 to 200 range, to saying, well, any amount of HIV virus replication is potentially bad and we should be being treated earlier. So the pendulum is swinging. The standard of care in the United States depends on which recommendations, which guidance you look at. But for the most part, there's increasing data that a CD4 cell count under 500, we really should be carefully considering therapy. The recommendations for all countries is under 350, but that guidance is in flux. And we won't talk a lot about the details of that, but it's important to know that the timing of treatment has impact on HIV infection, on transmission, and on the risk of TB. So this is where we were in the early 80s. And I know that many of you have seen the AIDS quilt, and each represents someone who has died from AIDS. So it was in an era when we really had no treatments, or we had a treatment that had no real efficacy over the long haul. I promise not to be political. That's not my goal here. It's only the words that are stated here. That we've come from, in the 80s, that an HIV diagnosis was very frequently, almost always, a death sentence, to a time when we can imagine an AIDS-free generation. So here's what's happened over time. Here we are back in 87. And these are annual rates of death due to the 9 leading causes of death among persons 25 to 44 years old. And here in red is HIV/AIDS. And you can see that in the 80s to early 90s, this was the primary cause of death in that age group. And it is now, has dropped down a very long way based on a variety of factors, but particularly on efficacious treatments, but also early diagnosis. Now, one of the barriers to early diagnosis of HIV in the past has been stigma. And stigma has not gone away completely. And for those of you who are in the mental health field, who care for HIV-infected patients, it's quite clear that this still is very much an issue. This is from Guyana, and the fact that a poster needs to state this: when sharing the bus, there is no chance, 0% in fact, of contracting HIV/AIDS. And this was on a bus. One of my nurse practitioners shared this with us. Her daughter was in Guyana and took this image last year. So here we are. This is data from 2011, and this is data in the United States. And this is called the cascade. So in the best of all possible worlds, what we've realized is that if we could take everyone who has HIV infection, know that they have HIV infection, have a diagnosis, treat them all, suppress their virus for all of them, that in fact you could go a very long way in preventing transmission, not to mention reducing the morbidity associated with HIV and the mortality. But this is the data. So it's believed we're close to 1.2 million in the United States that are HIV infected. Of those, 941,000 have a diagnosis. The others don't know that they're infected, this number. Those that are linked to care is 725,000. Retained in HIV care is about 40% of those total. on antiretroviral therapy, and then finally with a suppressed viral load. So that of all patients with HIV infection, it's believed that about 25% have an undetectable viral load. And we know that the aim is to be much, much higher than that. So we have potent, effective antiretroviral therapies. They're not easy. They are absolutely not easy. Some of them are relatively easy, but all of the care issues around HIV can be quite complex still. Despite that fact, and also it's believed, and there's some good data that's in the last year to show that someone with HIV infection who's treated, has a suppressed viral load and immune restoration can live a pretty normal lifespan. However, there's many challenges, and this is one of them, is assuring that patients who have an HIV diagnosis are not only know they are infected, but are in care and have treatment that's successful. So adherence is a huge area for HIV practitioners. Yes?
I have a question. I just want to make sure I heard you correctly. I thought I heard you say 25% have undetectable viral loads.
So in the 25% is, so this represents about 25% of all of the patients who have HIV infection, or who are estimated to have HIV infection in the United States.
Right, okay, so I did hear you correctly. Because a couple of years ago, I'm on the mayor's commission in Baltimore, and one of the leading doctors told us that 97% of those that are in treatment have undetectable viral loads. So it was a big discussion about it.
So
I think your answer is more to the point.
So this is the population, the denominator that you're referring to, is those who are successfully in care and on antiretroviral therapy. So you can see that the vast majority of those have a suppressed viral load. So that's...
What's the difference?
So the difference is one of our... So if we look at, so for the VA clinic, when we look at our numbers, for the patients who are on antiretroviral therapy, greater than 90% are suppressed.
Okay.
The problem is the patients who are not in care.
So the 25%, that represents those that are on treatment as well.
So they're on treatment. The problem is
I
that,
don't wanna hold you up.
that's all right. Well, the best way to look at this is that 75% of HIV-infected patients either don't know they have a diagnosis, or they know they have a diagnosis, but they're not in care.
Yeah. Okay.
But so let's talk afterward, because it's an important distinction, so that the therapies are exceedingly effective, and all of the data is on therapy. 90% of patients can be fully suppressed. Yes?
Just one question. So we're talking about all of these numbers come from all of the data from the whole United States that does reporting to the CDC.
Yes.
Because this is the MNWR. So it's possible for a jurisdiction to say, in our jurisdiction, when we looked at the numbers, 97% of our people, but if you're looking at the whole...
Yeah, but see, there's two things. One is, when you're looking at those numbers, you're looking at those patients who are in care
Right.
in a clinic.
Right.
But if they're not coming to clinic visits, then they're out there with high viral loads. And that's the dilemma. So 20% don't know that they have an HIV diagnosis. Another 20% aren't in care. And unfortunately, among the population of patients with HIV infection, that's not an uncommon scenario, that they're not in care. Yes?
One quick question. When I've heard 20%, you don't know, how do you get that number?
Where are these figures from?
Yeah, particularly those like the 1.2 million that are HIV infected, or, and, you know, including the 20% or so who don't, how do you get that?
So the CDC has a very aggressive, active HIV surveillance. So they, and a lot of folks don't know this, and this is typical for most cities and counties. So for the District of Columbia, it's a requirement that there is case reporting of every patient who has HIV infection. And that's pretty standard across the country. And the CDC spends innumerable dollars to really track this. And the reason the epidemiology is important is understanding the epidemiology allows you to appropriately manage the issues. And so based on this, there are enormous efforts in rapid HIV testing. Everyone should have an HIV test. It should be routine care. You don't need to sign a written informed consent anymore. It's an opt-out issue. Everyone should be tested for HIV.
Can I ask, what's the biggest block then to the people who, even the ones that know they're diagnosed, to getting treatment? Is it financial? Is it education? Is it a combination of all of those?
So it is. Those are two of them.
Okay.
Psychiatric illness, mental health illness can be a big barrier. Alcohol and drug dependence can be a big barrier. Adherence, even psychosocial issues related to homelessness can be very big. So of course this varies enormously by population that you're caring for, but those issues can be huge barriers. And there's patients who come to my clinic, they live in North Carolina. They come to my clinic in Washington, D.C. because they know they're not going to run into any people that they know from North Carolina.
I see. Because of the stigma that's involved.
Yes.
Okay.
And that's not standard, but that's an extreme.
It's one of them, though. It's a reason.
Yes, but there are enormous barriers to being in care. And if you look at something like diabetes, there's similar kinds of issues. So there's similar kinds of issues for other medical health problems. And is that? Oh, I'm so sorry, yes.
Even though we're looking at this nationally, when you take into consideration the inconsistency and see there's been a great inconsistency as to when people should be in care. There's really, just the last few years, they've been trying to get to a point to say, well, this is when a person should be required or should be suggested that they get in care. I mean, first the number was, and I've been in this for a minute, first the number was under 500, and it was under 350. Now it's too much flexibility. There's no across the board. When you identify a person, their CD4, their viral load, CD4 count at this point, or CD4 count at this point, then that's the time to look at it.
So you make a good point, and the question that's raised is, have there been mixed message about when someone should be in care? And you're correct that probably that patients are getting that message is, I'm fine, I don't need to be in care. The reality is what we aim for is that every patient with HIV infection is in care, very closely monitored. And as I go on, we'll come back to this. There's lots of reasons for that are unrelated to I need to start antiretroviral therapy today. So I'll move on, but we'll come back to some of those issues. So this is a new acronym. Familiar to anyone? Any takers? So this is TASP is treatment as prevention. So when you begin to look at the World Health Organization guidance, their view for the global HIV, is treating everyone under 500 is not possible. They don't even have patients who have a CD4 under 200 or 350. Not all of those patients are treated yet. So the recommendations are really to consider treating everyone under 350, but also giving consideration to high-risk scenarios. So serodiscordant couples. So this is, yeah, it's treatment is a T, as, A-S, P is prevention. And this actually doesn't project at all, does it? Okay, so I'll tell you about it. HPTN 052 is a study that looked at about 1,700 patients who were in serodiscordant couples, an HIV-negative man and whose partner was an HIV-positive man. So serodiscordant couples, and for the HIV-negative partner, either beginning them on placebo or Truvada, 2 antiretroviral agents. And what's very clear is that the patients who received Truvada for prevention had a very low risk of acquiring HIV. Now, all of these couples were advised about what high-risk behaviors are and to be protected. To use condoms was a part of the education for everyone. But what we know is even with all of that education, HIV transmission occurs. So treatment as prevention is the idea. That is not this idea. This is PrEP, and I actually, no, I'm sorry. The treatment as prevention is a separate issue, and I've gone on to PrEP. The treatment as prevention idea is the demonstration that if you treat patients and you lower the community viral load, the viral load overall, that you drop transmission in those communities. And that's been shown in multiple communities. All right, I'm sorry, my brain moved to PrEP. PrEP, that's a new acronym. And PrEP stands for, any takers? Yes, pre-exposure prophylaxis. And I'm going the wrong way, here we go. So PrEP stands for pre-exposure prophylaxis. And that is taking the discordant couples or treating other high-risk patients with Truvada. So taking an individual who is HIV negative, who has high-risk behaviors, who may be in a discordant couple or otherwise have high-risk behaviors, and randomizing them to receive either Truvada, an HIV medication, or placebo. Yes?
Question with this study, when they were administered the medication, the Truvada, were the couples sexually active? So you're testing before, during, and after?
So yes. So these are couples, it really was all comers who will have different risk associated with their sexual activity. The goal is, in any of these studies, is that the education is very aggressive about protection from HIV transmission. And it has to be. But you raised a very important point, which is there's a lot of controversy about this. And the FDA approved Truvada. This is an antiretroviral therapy that we use for HIV treatment, was approved in July for prevention, for PrEP, pre-exposure prophylaxis. Yes?
Oh, I was wondering about that date, because I thought they had been using that for a while.
With Truvada?
Yeah.
Yes, Truvada is an improved antiretroviral agent that we use. It's one of the most common agents that we use in practice in combination with other meds.
I thought they were using it for PrEP before the summer.
So in fact, it may have been used for PrEP, but the FDA approval is based on the data from HPTN, that earlier trial, and additionally from this trial, a trial called iPrEx, the Initiative in Pre-Exposure Prophylaxis. Right. And I'm going. Yes, a question?
Okay, Truvada is a combination of 3 different drugs. So when you administer this to a person, and you administer it over a period of time, and then, let's say you take them off that, okay, and their system has been exposed to these 3 different classes.
So I think, so the question is, yes.
So now their body, should they become infected, okay, they've already started to minimize the
You're wondering about resistance. Okay. So first thing to clarify, so one of these was done with Truvada, another was done with tenofovir alone, and actually it's tenofovir that was approved. What you're thinking of is a tripla, which is 3-drug combination, but tenofovir alone or Truvada, which is 2 agents in combination. The primary study in this case was Truvada, which is 2 agents. Your question relates to, is there a risk of resistance if HIV is transmitted? And the answer is theoretically yes, and likely yes. So that if a patient has already a resistant virus, then they can transmit resistant virus. And the Truvada or tenofovir and emtricitabine would not be effective in preventing. And that's a good point. The minority of patients have resistance mutations to those agents. However, if you take patients who do have resistance, the resistance to one of those agents is one of the most common. So there are, I hear from all of you all of the areas of controversy for people who are giving consideration to this. And this is brand new, and there is lots of dialogue and lots of thinking about what does this mean, and how is this implemented, and for whom should this be implemented, and how you do this and not send out a message that it's okay to not use condoms. We don't want to do that.
I read somewhere where it was like $1,200 a month, and how is insurance going to pay that? Something not $800?
So you guys raise all the key questions. What about who's going to pay for this? These are expensive drugs, $1,200 a month, $10,000 a year or more, a lot of money. So I'm not going to answer that question today. If y'all have the answer, just chime in. It is a very complex question, and I do think it's important to think about. I don't know if any of you were at the International AIDS Society meeting, but much of the theme was thinking about, can we overall reduce HIV in the world, and how do we go about doing that? So there's lots of things to consider. You had a question?
Do you have any numbers on how effective this has been?
Yeah, so this is the iPrEx study. And so it provides context. So this is 6% compared to about 11% of the patients in discordant couples had transmission. So you still have the challenge of taking the medications, possible resistance. So this is imperfect, but it does reduce the number of cases. So we will not solve this question today, but you'll be hearing a lot more about this, and it is a very important area in the HIV field. So we're going to go to TB and circle back around to HIV. I just want to make certain I have, time's 4:15, is that correct? 3:15, okay. So I have about 45 minutes or so. So TB, another infectious disease that causes great morbidity and mortality in the world. So this is from several years ago when the data was looking quite terrible in terms of death rate from tuberculosis, and in the 90s and towards 2000, fear that we had an epidemic that was not only not improving, but was really taking off. Sorry, this is... But it was in October of 2011 that we had, for the first time, news that the number of new TB cases worldwide had fallen for the first time in decades. So the glass is nearly empty, but not completely empty. The rates of TB cases is very high. And the number of deaths still from tuberculosis is 1.8 million a year, a number that's hard to fathom. Okay, going in this direction. Now, in the United States, the news is much better, and there's people in the United States that say, TB in the United States, is it still an issue? So it is good news, and this is the US from 1953 to 2010 in terms of the rates. So there's about 11,000 cases of TB in the United States each year. So it's far better than it was once. There's still a huge burden of disease. This pales, though, in comparison to parts of the world, particularly developing countries in sub-Saharan Africa and India and China, where the rates are enormous and the mortality is enormous. So as you can see, I'm challenged with my, my slide mover. Okay. So the organism. TB is transmissible person to person. It causes disease that is curable but not cured easily. It establishes latency. And that's one of the dilemmas, that about a third of the world's population has latent TB infection. Now, those are not the numbers in the United States. A third of the population in the United States does not have latent TB infection. But if you look at the global population, the rates of latent infection are very high. So what does that mean? So if you have latent infection, if TB is, say, transmitted, I think that's not working anymore, from this individual who's coughing, and you acquire infection, what happens? About 5% of patients will develop active tuberculosis within the first couple of years. Another 5% will develop TB sometime over their lifetime. But for 90% of patients that have a normal immune system, and note I've stated a normal immune system, they contain the infection. They have the little mycobacteria, typically in the apex of the lung, staying quiet. It's there, it's not replicating, it's not causing any trouble. But for 10 or more percentage, that can be associated with disease. All right. So you remember, though, that I stated that it is someone who has a normal immune system that has about that 5% risk of either developing active TB or reactivating TB. However, if you have any kind of illness that can affect your immune system, that risk goes up substantially. So all of these possible diagnoses are associated with a much greater risk of TB. Furthermore, patients with HIV infection have a phenomenal risk of TB reactivation. So their risk is somewhere between 21 and 34 times greater than someone who has a normal immune system. So it's a huge risk. And this is stated by the Global AIDS Policy Coalition. HIV multiplies the problems of TB for individuals and entire communities, and TB complicates the management and the course of HIV infection. So this is WHO data from 2010. And the countries that are darker, the rate of HIV among their TB patients is, the rate of HIV among their TB patients can be quite high. So for example, in South Africa, about 75% of patients with tuberculosis have HIV infection. So there are places in the world where the two illnesses, HIV and TB, come together in a very dramatic and a very awful way. So then the question is why? Why does this occur? So I would like for each of you to memorize this graph. All right. The long and short of it is that the immune cells and the immune control attacked by HIV is in many ways very specifically that immune control of tuberculosis. And so the CD4 decline very dramatically affects the risk of TB. And we'll come back to that, and you actually don't have to memorize it. So in TB, 8.8 million TB cases a year, 1.4 million TB deaths per year. There's 1.1 million TB HIV cases, with the majority of those in sub-Saharan Africa. Again, 21 to 34 times the likelihood of having active TB compared to an individual who has latent infection but has a normal immune system. And this is important. TB is a leading cause of death among people living with HIV. So among people living with HIV, globally, 25% who die from TB. So that's why this HIV and TB are so often discussed together, and why there are so many, if you go to whether at the international meeting or elsewhere, HIV TB has to be assessed together, has to be managed together. And this is, I won't walk through this, but it's just to say that the death rate among HIV-infected patients who have TB is much higher than if they did not have HIV infection. So if you look at percentages, 20% versus 3 or 4% die from their TB. So I want to say a word about TB diagnosis, because TB diagnosis is a real dilemma. With HIV, we have very simple tests that tell us right away if someone has HIV infection. With many illnesses, we know right away. With TB, we can be months away from knowing that someone has tuberculosis. So this is usually the steps to diagnosis: a smear of a sputum that's coughed up. They look at that under the microscope. Now, unfortunately, that's helpful in 60-ish%, but if you have HIV infection, that's not a great test. The culture requires lots of resources to do all the culture methodologies that most countries who are faced with HIV-TB may not have resources for. So culture is reserved only for those who are failing treatment. So this is the current approach in many countries. A patient is suspected of having TB. They have the smear of their sputum. Now, if it's negative, they're not treated, and there's recent data that suggests that it can be 4 to 5 months before that smear-negative patient is treated for tuberculosis. So that's 4 or 5 months when they are ill, possibly, out in the community infecting other patients, other contacts. So if the smear is positive, they're treated, and it's only if they fail treatment that the culture is done. So it's an imperfect process. The good news is that there are some new rapid diagnostics, and these are some of them, and the names won't mean very much. But the important thing is to say the idea here is you can take an individual day 1 from their sputum and looking at the DNA or RNA know if they have TB with pretty good certainty. So we're sometimes taking that from months down the road to day 1. This is one of the technologies we're evaluating in a clinical trial now in the United States, but it is approved in other countries. And the beauty of it is that all of the reactions that are needed take place inside the box. So you put the sample in the cartridge, an hour and 45 minutes later, you have a piece of paper that says, does this patient have TB? Does this patient have drug-resistant TB? So this is a dramatic advance. There's also tests that are done in HIV-infected patients that may, in combination with this other test, improve our diagnosis by testing the urine. Now, it's important to be creative. This is true. The Gambian pouched rat in Tanzania has been investigated, and it turns out that this creature can detect TB in sputum better than smear. Now you can imagine laboratories or having this in your clinic could be a challenge. But actually, if you have too much time on your hands, the YouTube videos on the Gambian pouched rat and TB diagnosis are fascinating. These are the same creatures who actually can detect landmines. So they're pretty dramatic. And this is related to an amine that's released, and it's via smell. But this isn't the answer, but it is interesting. So if we think now about treating TB, what's the big deal? Why can't we just treat this infection? This is a curable disease. What's the problem? So here's the challenges of TB treatment. First of all, you have to treat a long time. 2 weeks of therapy doesn't do it in tuberculosis. It's months. And we'll come back to that. Second thing is that we know how difficult it is to take medications. And in tuberculosis, where the public health challenges are so significant because of person-to-person transmission, it has long been demonstrated that doing directly observed therapy for TB treatment, so the caseworker goes to the patient's home or the patient comes to the health department, that you improve the chance of curing the TB and you reduce the transmission of TB. The other thing is that we can't treat with a single drug. We need many drugs. And our drugs are hard. They're not easy. They have a lot of toxicities. Yes?
Aren't you talking about two different things? Latent TB infection versus TB disease?
Yeah, and I may not have transitioned as well as, so let me make that distinction, because it may not be clear from these slides. The question is what's latent and what's active? So latent TB is, again, I said it's there in the lung, it's quiet, nothing's happening, not causing a problem. What we know about it is that it can reactivate, and that risk of reactivation is very high if you have a weak immune system. If it reactivates, then you have active TB. And active TB is where the patient is sick, often coughing, can transmit TB to others. Okay. If you have latent TB and the germ is sleeping, you cannot transmit TB. So what we're talking about now is active TB, folks who are sick with tuberculosis. And the the 8 million patients with TB in the world are the active TB patients. The third of the population of the world with TB is latent TB, so the sleeping germ. So here's the problem, is that our standard therapy for tuberculosis right now is 6 to 9 months of therapy. It takes a very long time to treat. And the drugs can be challenging. So I'm going to touch on 4 items that I think are meaningful, and I'll try to move through these quickly. But I'd like to just give you an idea of what's involved when you're thinking about an HIV-infected patient that you want to treat for tuberculosis. So the first thing is that patients with HIV infection develop more resistance, TB resistance, more easily. So if we think about a patient, this is someone who is 51 years old, has HIV infection, a CD4 of 68. They have 3 weeks of cough and sweats. They have a history of hepatitis C, tobacco, alcohol use, and currently reside in a shelter. And this is very typical of the patients. This is a patient from the VA actually, and very commonly a patient with tuberculosis is not a very, very healthy individual, no other medical problems than TB. They very frequently have a comorbidity or several comorbidities or complicated lives that make it hard to treat. And their sputum shows that they have a smear that's positive and their culture grows TB. This is another patient with HIV infection who has, this patient didn't present with cough, but with huge lymph nodes under their arm. So the first thing is, what about giving intermittent therapy? When we treat TB, we've shown that you can give therapy twice a week for the majority of the time. However, if you do that in the setting of HIV, those patients develop drug resistance. And drug resistance is a problem because the TB becomes very hard to treat. So these are the reasons that intermittent therapy is meaningful. But the important thing is that early on in HIV-infected patients, we can't use intermittent therapy. And that's, again, because of their weak immune system. This is the TB Trials Consortium, which is a CDC-sponsored consortium that our group at the VA, in collaboration with Montgomery County, is part of, with the aim of improving the treatment of tuberculosis. So shortening therapy, making therapy better. But we've also studied HIV-TB and know that in patients with HIV infection and intermittent TB treatment, that those patients develop acquired drug resistance. All right, you've got this memorized already. I think we're good. The second thing is this. These are the antiretroviral agents that are approved for the treatment of HIV infection. And the problem is, if you try to treat HIV infection and TB infection together, it's difficult. And the reason is that the drugs interact in such a way that the HIV medicines may not work. So the main medicine for TB that's key is the rifampins or the rifamycins. And those drugs drop the levels of some of the key HIV medicines. So that makes it more complicated. The third thing is something called IRIS, immune reconstitution inflammatory syndrome. And what happens here, we're going back to our patient. You remember this gentleman. So this is a fever curve. And so if my pointer's not working anymore, but if you look towards the left, we're back now in 2000. In March of 2000 is when the patient started their TB therapy. And then in April of 2000, we started the antiretroviral therapy with the TB therapy. Now, 2 weeks later, this patient is having huge fevers, very high fevers. They don't feel too bad, but they're having big fevers, coughing a little bit more. And what this reflects is not that the TB has gotten worse, it's just that we treated their HIV, and now they have a suppressed virus, and their immune system works so much better that it's responding to the TB germs that are there. They have a strong immune system now. Additionally, this is what was found. The area in the center that is black, I don't know if there's another pointer anywhere, shouldn't be there. I'm going to take my word for it. The patient with the big lymph nodes had a similar scenario. They started their TB therapy. They were doing great. The TB therapy was continued. They started on the HIV therapy because we'd like to improve their immune system. But when we improved their immune system, they actually got fever and developed abdominal pain. So this patient, you can see where the arrow is, developed big collections inside the abdomen that was their immune system now that's stronger, responding to the TB that's there. So what does all of this mean? And I won't go into the third patient, but you get the idea of what's happening here. IRIS is development of inflammation at a site of pre-existent infection following initiation of therapy. And it's an indicator that the antiretroviral therapy is working. It used to be called, quote, a heart attack, meaning highly active antiretroviral therapy. What the important thing about this is we don't want to stop the HIV therapy, and we'll come back to that, but that this can make treating TB in someone with HIV challenging. So finally is the question, you have a TB patient, they have a new HIV diagnosis. When is the right timing to begin their antiretroviral therapy? So let's go back to our patient from earlier. Let's say it's the gentleman who's 51 years old, but his CD4 is now 49. His immune system is exceedingly weak. Same patient. He starts his TB therapy. 2 weeks later, he's feeling wonderful. He has an appetite again. His appetite is improved. He's gaining weight. His albumin is better. He's doing better. But he has HIV and a really weak immune system. When should we start antiretrovirals? So the possibilities are to start now. Should we wait until the completion of 8 weeks of therapy? Or should we wait, in fact, until he completely completes the TB therapy? So all those voting A, start now, a raise of hands. So a few people are willing to start now. Start after about 8 weeks, okay? And wait till we've completed the TB therapy in 6 to 9 months. So really most of you thought waiting 8 weeks or so is the way to go, because I've just explained to you how complicated it is to treat them together. And that's what we all thought. We all thought that was the right answer because it's complicated to do this. So the first thing that we showed, there's 2 trials that I'll show here. The main thing is that if you give therapy together, patients are more likely to survive. Okay, so you have a higher death rate if you wait until after the TB therapy is complete to start the HIV therapy. But the second thing is that 3 studies done all at the same time showed that in patients who have a very weak immune system, a CD4 under 50, if you wait more than a few weeks to treat their HIV, they're far more likely to die. So the data showed what we hoped it wouldn't because we'd like to wait and it's hard to treat them both together. But the answer is that for patients who have really weak immune system, if we don't get their immune system stronger and suppress the HIV virus, they're not going to do as well with their tuberculosis. And so we have to treat them early. The good news is that we have drugs that are easier to use together with a TB therapy. And that's always a focus as we're thinking of new drugs for TB is, can we give them with HIV therapies? So, yes.
That was a hard one because I saw the alcohol and homelessness about that guy.
Yes.
So I was wondering, you know, heart therapy would probably be held off in some cases, right?
Yes. So you raise a really important point. The question is, what about the fact that they're homeless and they drink alcohol? So what I would say to that, I guess 20 to 30 years into taking care of patients with exactly these issues again and again and again, is that it's hard, but you do everything possible to bring them in care. You have all of the resources you can. We finally have an HIV psychologist in our clinic who is also an adherence specialist, and there will be invaluable. You work very hard with integrated social work services and supports to care for those patients. It's not to say that we don't fail, because we do, but our aim is to do everything possible to have those patients in care. And sometimes it's meaningful. Patients begin to understand with a lot of supports, you know, the physician, the nurse practitioners, the psychologists, the social workers, at every level, the caseworker giving the tuberculosis therapy, at every level emphasizing to that patient what's needed for them to get better, it can be meaningful. So yes, you're correct, it's very challenging, but it can, we aim for that to be done. So, and I think that this is the WHO from many, many years ago, and you can understand why King Kong and Godzilla are represented as HIV and TB, and it was working together against us. So, but I think that it's time now that we're working together against tuberculosis and HIV infection. And let's see. Are you guys hanging in there? I have just a few more minutes to go on. Before I go on, you have a question? Yes.
Would that be an inclination to test that person for HIV?
So the question is, if an individual is coming into a treatment program and they have a skin test for tuberculosis, should they be tested for HIV at that point? And the answer is absolutely, yes. So the easy answer is everyone should be tested for HIV infection. Having said that, and there's the rapid test, and that's implemented in some areas, not everywhere, but it's an oral swab. And that test is not the definitive test, but if that's negative, that's a true negative, that the individual doesn't have HIV. If it's positive, then you have to have a next step, the blood test, or the Western blot, to assure that that's truly positive. So the easy answer is to say that everyone should be tested for HIV infection. Specifically when you're considering someone who has a positive skin test, you want to know if their HIV status. Because what you recommend to treat their latent TB infection, that we're not getting into that today, but what you're going to recommend for that will depend on their HIV status and whether you're treating their HIV at the same time. But if they have HIV infection and they have a positive skin test, then you absolutely want to treat them for latent infection to prevent them from having active disease, because their risk of having active disease is so high. Is that making sense?
Yeah, well, it makes sense to me because, I mean, it's like standard procedure going in the program, that the program requires that you be tested for TB, but they don't require that you be tested for HIV.
So please address that locally.
Well, it's standard
Yeah.
in Maryland, or
Yeah.
you go into treatment,
Yeah.
into a treatment facility, or into a program.
Yeah.
They
So
require that you take a TB test. to come into that program.
Yes,
They
and
don't
I,
require that you take a HIV.
right. Well, so there are really two different issues. The issue of doing the TB test is determining if there's someone who has active tuberculosis so that there's not transmission. So it's an immediate issue. The issue of HIV that I'm reflecting is the global question that everyone should be tested for HIV infection and know their status. It doesn't have the same immediate urgency to a disease that's communicable by coughing and sharing a space. So it's not usually a space like this, but smaller rooms where you're sharing the space for hours and hours, you can transmit TB. And so it has immediate implications. I think that it's not policy because the immediate HIV result doesn't have that immediate meaning in the program. For the individual, though, it has meaning, and for the community, it has meaning. And it may be that those programs really rely on their primary care docs to manage that issue. They don't always. So good questions. So the first thing is to say that treating latent tuberculosis infection has improved worldwide, and it's improved in areas where TB is the highest. The second thing, is that if you treat HIV and you improve the immune system, you reduce the risk of TB. So treating HIV treats the individual, reduces transmission, reduces their risk of tuberculosis. And so this is the UN AIDS goal of 0 new infections, 0 discrimination, and 0 AIDS-related death. And we'd like to add 0 new cases of tuberculosis. This is from the International AIDS meeting, and it's a activist group, and on the left it says no more persons living with HIV dying of TB, and that's actually a coffin at the bottom. Stop TB. And so the recognition that these HIV and TB are very closely intertwined, and that illness related to this intersection is great, and we need to both prevent TB and prevent HIV and improve how we care for those patients. So, this is a very, very long list of collaborators in the TBTC. We're a very big group. Any other questions? Okay. Good, thank you very much.